Hello, everybody, and on behalf of York Hospital, welcome to today's webinar. Today we will hear from two presenters from cardiovascular care of York Hospital about ways we can improve heart health. While today's presentation does focus on women and cardiovascular disease, there is plenty of good information and advice that also applies to men. We'll first hear today from Dr. Erin Rafferty, who will explain the importance of getting screened annually, paying attention to signs and symptoms of cardiovascular disease, and getting comfortable talking to your doctor about your heart health. Following Dr. Rafferty, we'll hear from Dr. Krista Michelin, who will highlight the importance of knowing your risk, how you can reduce your risk, and tips to talk to your doctor about whether or not you're a candidate for further testing or medication for disease prevention. Before we go and get started, we have a few quick housekeeping notes to review. Unlike in a traditional Zoom, when you see everybody's faces during the meeting, during today's webinar, you will only see the presenter's face and slides. As participants, your audio has been muted, so if you do decide that you have a question, you can type it into the Q&A button located at the bottom of your screen. Please do not use the chat or raise hand icons, as those will not be monitored during today's call. If you have a question through the Q&A feature and it is not answered during the meeting, which it most likely will be, you can email us after at info@yorkhospital.com, and we will be sure to get an answer to you after the call concludes. This webinar is also being recorded and will be available on the York Hospital YouTube channel next week. So now, once again, thank you very much for tuning in today and spending this time with York Hospital. We hope you find the information helpful, and we're pleased to go ahead and get started by turning the program over to Dr. Rafferty.
Hi, welcome to everybody who's here. I was looking as people were starting to come in. I see some familiar names. Thank you so much for giving us your time today. We're really excited to be with you virtually. And for those of you that I know, some of this may be redundant. Basically, the reason that we are here today is Go Red, and it's a month in February where we take the time to really focus on women's heart health. And the reason we do that is because it's the #1 killer of women. It's the leading cause of death for women in the United States. And it causes more deaths than all cancers combined, including breast cancer. 1 in 3 female deaths. And the good news is that mortality is declining overall, but more slowly for younger women. And sadly, 64% of women who die suddenly of heart disease have had no prior symptoms. And despite the fact that this is such a huge problem, there was a survey done in 2014 of women in the United States between 20 and 60 age 20 and 60, and 45% of women were not aware that heart disease kills more women than cancer. There was a specifically lower awareness of this among minority and low-income women. And interestingly, women said they rarely or never discussed heart health with their family and friends. And largely this is because there is a social stigma regarding body weight and the idea that heart disease was an embarrassing diagnosis. 45% of the women surveyed said that it was common to cancel or postpone an appointment with a doctor until they had weight loss. And so you can imagine this is this self-fulfilling prophecy where women don't get evaluated, they don't come to appointments, and ultimately these things get worse. And the idea that people said for why it was embarrassing was that heart disease was linked to this idea that it's something that you're controlling, that you're not eating right or you're not exercising, and there's this sense of shame associated with the diagnosis. So it's a big problem, under-addressed, and a lack of understanding in the community. And so this is an illustration that largely describes that again, it's the #1 cause of death. 400,000 women died from heart disease in 2016. These numbers here about the awareness of it. And then interestingly, it's not only patients and people in the community, but primary care doctors. So 40% of the time, if you go in for a routine check with your primary care doctor, they're going to ask you about your cardiac risk and go over what your risk is and how to modify it. So we know that when we go to these appointments, mammograms, colonoscopies, these kinds of things are addressed pretty regularly. But heart disease, which is arguably the most important thing that should be discussed, is not discussed the majority of the time. And this graphic also describes that 39% of PCPs make cardiovascular disease a top priority. Now, understandably, there's a lot of competing interests and a lot of things that need to be addressed in a short amount of time. But you can see just from these few basic ideas that it's a huge problem. There's a lot of stigma associated with it. And even when you do get to the doctor's office, oftentimes the issues aren't addressed appropriately or effectively in a way to really make an impact on the outcome. So additionally, once you do make it in and then you start to talk about treatment, women who have established coronary disease, so what that means is that we know you have a blockage in an artery, maybe you've had a stent or a bypass surgery, you're less likely to be treated with medications like aspirin, statin, and ACE inhibitors. And these are medications that in trials have proven to improve the length of your life. And if you're treated, so if you do get on some of these medications, the treatment is less likely to be as aggressive as it should be, or it's less likely to achieve optimal effectiveness. So maybe you get on a dose of medication and it's okay, and it doesn't actually get pushed to where it really should be. Women are less likely to get lifestyle advice or be treated for high cholesterol than men, and they're less likely to be referred to cardiac rehab after a cardiac event, and they're 55% less likely to participate, which gets into the issue of caregiving and other responsibilities, that kind of can supersede self-care. So that's the basics to say it's a problem. We need to make some change in how we address it. And so what I'm going to do to differentiate from what Dr. Michelin is going to do is I'm going to talk about what you can do at home, what you can do right now with the information that you have to kind of assess where your risk is. And then Dr. Michelin will talk about things that we as cardiologists and doctors do to kind of enhance that risk evaluation, that risk assessment. So most people know these are the traditional risk factors for coronary artery disease. These are pretty widely discussed. And the idea is if you have a family member, so a first degree relative means 1 degree away from you. So your mom, your dad, your sibling, and any member of your family, in a man that's less than 55 or a woman less than 65 that has a history of heart disease, that infers some risk to you as a patient. You have diabetes, high cholesterol, smoking, high blood pressure, or inactivity. And those are things that are pretty well discussed and addressed. However, in women, there are other things that have emerged over the last decade that are additional risk factors that we need to consider when we think about the overall risk to the patient. So on the left, you can see these are the traditional risk factors. And on the right, these are things that we now know have an impact on your cardiovascular health. So things like preterm delivery, things like hypertensive disorders of pregnancy. So if you have high blood pressure throughout your pregnancy or a diagnosis of preeclampsia, gestational diabetes, so diabetes during your pregnancy, autoimmune disease. So things like the most popular rheumatoid arthritis is a really common one. And women who have rheumatoid arthritis have almost a 4 times fold increase of cardiovascular disease. Breast cancer treatment. So that includes both chemotherapy and radiation. And depression. So mental health issues also have an impact on your heart health. So this is a slide that basically just says things that put you at risk. And most of this stuff I've talked about. But if you took a screenshot of this and kind of looked through these things, it's all the things that if we see you in our office, we're sort of thinking about as we're having a conversation with you. And I'll go through it quickly. But the idea is in cardiology, what we want to do is try to get a sense of, are you at high risk, low risk, or in the middle? And most people are in the middle. And that gray area is where it takes a little bit of finesse and conversation and communication between patient and doctor to sort of say, do we think you're going to be more in the high risk spectrum or the low risk spectrum? And these things all go into the mix of how we help to decide that. And then we have imaging things and other testing that we can do to kind of help enhance that understanding to decide what the best treatment is for you. So smoking, high blood pressure. And so that includes, so high blood pressure is defined as 120/80. But I hear a lot of people say, I have high blood pressure, but I'm on medications and it's great. So I don't have that problem. But it is, even treated high blood pressure is considered a risk factor for cardiovascular disease. Oops. Sorry. Cholesterol, same thing. So greater than 200 for your total, or if your good cholesterol, so that's your HDL is less than 50, and that's especially true in women, or you have treated high cholesterol and you're on a medication, that's still considered a risk. We still think about that when we're kind of assessing how we think about your overall risk. Obesity, so again, autoimmune diseases, lupus, rheumatoid arthritis, preeclampsia, gestational diabetes, high blood pressure, poor diet, physical inactivity, family history that we talked about, metabolic syndrome, so not quite diabetes, but trending in that direction. And then evidence of atherosclerosis on some other imaging kind of test. Sometimes we get in consultation people who've had a CAT scan for other issues and are noticed to have calcium, in the heart. And so they'll want us to kind of have a conversation about what the risk is for that person. Coronary calcium, which you'll get a little look at on Dr. Michelin's slides, kind of what that looks like. If there's a high level of that, we think about that in a different way. And then thickened or plaque in your carotids or in your legs. And finally, just an inability to exercise, so poor exercise capacity. So why do we care? Because of this picture exactly. Because what happens is on the left is you have nice, normal, beautiful arteries. There's no plaque buildup. And as you move to the right, more and more plaque builds up. And the two that I want to really kind of focus on is this one right here and this one here. So on this slide, you can see this is all plaque buildup. And this white space is where the blood goes through. And this is it in cross section. So this is kind of where the blood has to go through around this plaque. Now, if you're a sedentary person, you're sitting in your chair, sitting on your couch and not doing much, the body is built in such a way where this blood flow is sufficient and you feel great. You would have no idea necessarily that this was there. When you start to exert yourself, climb flights of stairs, go on the bike, do something more vigorous, that amount of blood flow and oxygen delivery becomes inadequate. And that's when the demand of the heart, it starts squeezing harder, it starts squeezing faster, and it's asking for more blood. And that vessel can't meet that demand. And that's when you start to get pain, and we call that angina. So it says below it, exertional angina. So it's the kind of symptom that if you are really not pushing your body in any way, you might not know exists. But if you are active, you may become aware of some symptoms, chest pain, shortness of breath, nausea, when you're doing something exertional. And then what happens is you rest, you stop because it doesn't feel good. And that supply-demand mismatch that's happening resolves and the symptoms go away. And so that's obviously something we would want to talk about, but that's kind of the mechanism of how that works. Now, over here is a heart attack. So what happens is that plaque becomes unstable, and you can see right here it's ruptured. And so inflammation, stress, different kinds of things contribute to why this happens. And this is the kind of thing that comes out of the blue. So it's not happening when you're exertion. It's all of a sudden chest pain, discomfort, because what happens is this plaque ruptures and the blood flow that used to be kind of compromised is now nothing. So the parts from inside here have come to the middle part of the lumen of the blood vessel and are now blocking blood flow. And so there's no oxygen getting to that part of your heart. So that's a heart attack, that's an emergency. So our whole goal, Dr. Michelin and I see a lot of people that this has already happened. But what we're talking about today is how do we prevent everybody from getting to this spot in the first place? So that's the mechanism. So those are a lot of things. So that risk slide that I showed you had a list of a lot of different things. How do you decide if you have 2, if you have 5, if you have 7? How do you decide what to do? Is there a magic number of those things on that list that would make us feel like you should be on medication? Or so this calculator is a way that we've tried to put a little bit of organization into thinking about your risk. And you can actually do this at home. ASCVD, risk estimator, it's right here. You can actually type that into Google, and you'll get it in a way that you can just type in your own information and it will give you a percentage. So it's helpful if you have your cholesterol information at home. And what we used to do is basically say, we would do a lipid panel and we would look at your bad cholesterol and we would say the number is high, low, treat or not treat. And it was purely based on this one number, this LDL. But it didn't take into consideration anything about who you were as a person. So now they're saying, we think it's more complicated than that. We think we need to know if the people are diabetic, if they're on high blood pressure medication, if they smoke, what their cholesterol is, how old people are. And we think these factors should weigh into the decision on the risk, how you assess someone's risk. And so I think that makes a lot more sense, because if you have someone who has no risk factors but an LDL that's not great, maybe they don't really need a cholesterol medication, but someone whose LDL is not too bad but has all these other risk factors, obviously that nuance is important. So we'll spit out a number and it will tell you what your risk is of having a heart problem in the next 10 years. So these are the guidelines that we use. So it's really easy for us to make a recommendation if you have heart disease. If you had a heart attack, if you had carotid disease, you've had a stent, you've had a bypass, you should be on a cholesterol medication. If your bad cholesterol, which is your LDL, is 190 or greater, you should be on a cholesterol medication. If you're diabetic, between the ages of 40 and 75, and your LDL, which is your bad cholesterol, is above 70, you should be on a cholesterol medication. So those issues are largely taken care of at the primary care level because it's pretty easy. It's straightforward decision making. The people that require a little bit more discussion are people who don't have coronary artery disease, and we're talking about prevention. And that's a little bit of a harder decision because people say, because you can't look in a crystal ball and find out who's going to have a problem and who would benefit from a medication and take it just to prevent something from happening 10 years down the road. It's a harder question to answer. And so based on some trials, the idea is that if your 10-year risk, based on that calculator that I showed you, is 7.5% or above, that breakdown would suggest that you might benefit from a cholesterol medication. Other people that we would have a conversation with, if you have a very strong family history, so someone less than 40 years old in your family had a heart attack, or your LDL is not quite 190, but 160, and maybe you have some other risk factors. Other people is women greater than 60 who have these other things that may show inflammation or already some plaque buildup, a CRP level that's elevated, a coronary calcium score greater than 300, or an ABI, which is an evaluation of the blood flow in your legs that's not quite normal. So it's women at a certain age with these other things that are showing that there's already some atherosclerotic disease that's been developed. So briefly, cholesterol is just this fat-like substance. I already showed you what it looks like. It builds up in the walls of your arteries and it leads to heart disease and stroke. There are no symptoms of it, but we know that lowering your cholesterol can lower your risk of having a heart attack. And specifically the good cholesterol, so the HDL, if that's especially low, that can be a notable risk factor for women specifically. High blood pressure, just a couple of quick things about high blood pressure. It tends to be sort of under-addressed. Half of all adults in the US have high blood pressure or they're taking medications for high blood pressure. Only a quarter of the patients who have high blood pressure are well controlled. 45% of Americans who don't have controlled high blood pressure, their numbers are 140 over 90 or higher. That's 37 million Americans. And high blood pressure, we don't feel it. It doesn't feel bad at all unless it's extremely high and headaches and visual. There are things where when it's in an emergency, but in general, just borderline, not great blood pressure, we don't feel it and it's an easy thing to ignore. So a couple quick things. Heart attack symptoms. This is a really common thing that I hear a lot in the office, that women's heart attack symptoms are different than men. And this is a nice slide that just sort of demonstrates the bottom line is that the most common symptom of a heart attack in all people, regardless of gender, is chest pain going to the jaw or to the arm. So that's the most common thing for everybody. But women additionally have fatigue, sometimes indigestion, sometimes more abdominal discomfort, shortness of breath, these types of things. So it's just important to be aware of those differences, but to still understand that the most common thing is still the most common thing for everyone, which is chest pain. Women tend to have fewer warning signs, so it can be a little bit more sudden that way. And then these three issues could be a talk in and of themselves, but when people come to the emergency room with chest pain, sudden onset chest pain, they come to the emergency room and we get blood work, and the blood work shows that there's been some stress or some damage to the heart. The most obvious thing is what I showed you, which is a plaque in an artery that we fix with a stent or surgery or these types of things. But women have these syndromes, Minoka, Takotsubo, and SCAD, that are essentially present like a heart attack. It seems like you're having a heart attack, but they go in and they look at the arteries of the heart. And it's not plaque-based. It's not like what we described earlier. Minoka is when there's no blockages, and the reason for that is maybe there's some spasm of the arteries or tiny plaques that have been sent down into other parts of the heart. Stress cardiomyopathy is something like an emotional stress or a physical stress that causes this release of catecholamines and it weakens the heart muscle. And then SCAD, which we see oftentimes in pregnancy, is when the wall of the coronary artery is dissected and it kind of comes apart a little bit. So there's a lot of research going on a lot of these things, but just to say that some of the manifestations of heart disease in women are different, and they require a little bit more research, going forward, and further conversation about what this means. Because just because you don't have blockages on the catheterization doesn't mean that there's not something going on that needs to be optimized. So my take-home points, which are, it's too soon because Dr. Michelin's got a lot more to say, but just, it's a big problem. It's important to be aware of where you stand and some things you can do for yourself. And then sometimes things it's helpful to have a doctor, primary care, maybe especially a cardiologist, to kind of talk these through with you and help figure out where you are on the spectrum and what we can do to get more information about where you are on the spectrum. And really the thing is, get comfortable about asking questions about your heart health and working on these stigma related to heart disease, because it happens to a lot of us. And there are factors beyond our control that are contributing to this. But the things we can control, we should really work hard to do that as soon as possible. So, and I'm happy to answer questions when we're all done, at the end. Turn it over to Dr. Michelin.
Good afternoon, everyone. I'm happy to be here along with Dr. Rafferty to talk to you all about cardiovascular health. And I'm hoping to build a little bit more onto the thorough review that Dr. Rafferty just gave about our risk factors and assessing risk. And so hopefully it will expand on some of those points a little bit. So like Dr. Rafferty mentioned, it's really important for us to think about this for all patients because assessing cardiovascular risk is important to everyone, but in particular, remembering that it is something that women develop, and we have tools for prevention that oftentimes we sometimes forget about for some reason, even though I think the education is really trying to get out there that it is something that affects women as much as men. And so just kind of reiterating that important point that it's important to know your risk and to further discuss ways of reducing the risk. So most of the pieces on this slide, Dr. Rafferty outlined in detail, which is wonderful. I just wanted to take a moment to point out, and I thought this slide kind of showed this illustration, all the puzzle pieces. So really pointing out that cardiovascular disease is a multifactorial problem. There are a lot of things that contribute to it and a lot of components that join together to give us our ultimate risk, and that so many of the things that are on this slide are risk factors that can be modified. So I think that on the one hand, it makes it more complicated because we can't just fix it with giving one medication like an antibiotic and curing an illness because there are so many features that go into the development of disease. But on the flip side, we can be empowered to make decisions in our lifestyle that will significantly modify our risk over time. So just to kind of reiterate that point, that there are a lot of components that go into it, and that we can target all these different areas to help overall bring our risks down. So just a step further in giving an assessment of risk, like Dr. Rafferty mentioned, that nuance that's really important when we try to think about risk instead of just kind of in a general sense, can really help us make decisions about how we'd want to address that risk. And something you would want to do in collaboration with your doctors, your team, to help you kind of sort through what that risk is and whether you should be considering some of these more advanced nuances and making the decision about your risk in order to make different decisions about how you might treat it. So Again, Dr. Rafferty mentioned this general concept here of, and it's easy to kind of figure out those of us that are in the high risk category and those of us that are in the low risk category. But that middle risk or intermediate risk is the region where the more advanced risk stratification options can become more clinically meaningful, because they can help sort of move us in a direction on the spectrum of risk. And obviously, we would like them to move us into the lower risk category. But if the results of our overall assessment, including all of the major risk factors that Dr. Rafferty mentioned, and the pieces that we use in order to the risk calculator that she talked about, and plugging in all of our numbers into that category. We also can use all the other sort of potential risks that these risk enhancing factors that Dr. Rafferty mentioned, like inflammation and other rheumatologic diseases and other features that make you unique, to really assess where your risk falls. Can help us decide really more specifically where you fall in terms of risk, and then how we might address it. And I will get to that, how we might address it and how we make those decisions. So this is a slide talking, sort of pointing out a little bit about blood tests that we can do to use to more specifically assess for risk beyond just the typical blood cholesterol levels, measuring your blood pressure, your visits, talking about your lifestyle choices. And the reason that sort of took us on this path of being able to be more advanced in our discussion of risk was started off with the high sensitivity CRP. Now, I'll mention that these blood tests we don't use as often right now in terms of assessing risk, but they are, at least the high sensitivity CRP was what kind of started the discussion about more advanced risk. And it was a number of years ago now, a study was performed in looking at people in a cohort of primary prevention. So people who have no history of cardiovascular events like heart attack or stroke in the past, and looked at their cholesterol numbers. And as Dr. Rafferty mentioned, we used to use just a hard number cutoff. If the number was high enough, then you got a statin. And if it was below that, then you didn't. And that was the only thing we considered. But this study really brought up the question of whether or not we might get further benefit if we considered a more broad approach to looking at a whole person. And it took people that we couldn't previously have had cholesterol numbers in a range where we would have considered medications, and risk stratified them. So people that had a high sensitivity CRP, which is a marker of inflammation, seem to benefit in the outcomes from taking statins. And that really helped, which is impressive because it was able to show this in a primary prevention population of people where the event rates tend to be lower because it's a healthier group of people. And so for there to be a demonstration of benefit in that group at reducing cardiovascular risk from statin medications was a pretty powerful driving force to adjust our guidelines to assessing risk as the main decision maker, and to help this idea of further risk stratifying to really be as precise as we possibly can about what your risk is, so that we can feel good about the decisions we're making in terms of not only making lifestyle choices that will reduce risk, but whether to consider medications. The lipoprotein little a and the apolipoprotein B are two other more specific sort of subcategories that have been shown to be markers of increased risk. But we really need more data to help us determine whether or not that really makes a big difference in the risk stratification decision making. And what's kind of taken over more in terms of risk stratification has been the coronary artery calcium score. And this is a scan. It's a CAT scan that we can do actually right at York Hospital and across the country, that looks at the arteries and is able to calculate a score of calcium within the arteries, and it comes out into number zones. And it is, we know that the more calcium there is in the arteries, that the higher your cardiovascular risk. So it can be really helpful in particular in people who fall into that middle zone of whether or not they should be more aggressive or more proactive about their prevention plan as compared to people who don't have any evidence of calcium in the arteries. And this has actually been pretty well studied, and we know that the risk of cardiovascular events, at least in the short term, like over the course of a year after a calcium score, if it's 0, then the event rate is really exceedingly low. And then the higher the number is associated with higher calcium and higher cardiovascular risk. So certainly it would really significantly change our thinking about your risk. And I think that helps people make decisions about what they would like to do about that risk by having a little bit more information. And so the calcium score can be really useful to help us. And that is the mainstay of our more sophisticated or advanced risk stratification right now. But I do think that this is a really big area right now that is being studied, and we're likely to come up with more tools that we can use over time as well. So right now, the risk calculators are a nice tool because they can start us off. We use it based on our age and gender and our cholesterol and blood pressure numbers. And, it gives us a general starting place of where we are in our cardiovascular risk. But like Dr. Rafferty mentioned, there are these other risk enhancing factors, but we don't necessarily know how much weight to assign to those in terms of assigning the level of risk. How much more does your percent go up because you have a family history, or because you had an exposure to secondhand smoke, in childhood, or because you had elevated blood sugars during pregnancy? We know those affect risk, but how much it changes that number is uncertain. And so that's really where a clinician and patient discussion can really help to decide how many of those other risk enhancing factors do you have as part of your history and your overall health, and does that influence, how does that influence your risk, and would you be a candidate for further risk stratification to making a decision about treating your cardiovascular risk or approaching it. So this is a look, and it's similar to what Dr. Rafferty showed in the atherosclerosis, but more specific to the calcium score. On the left, again, is a normal-looking artery without any evidence of plaque. And then as you move toward the right, you have more plaque and more the little white specks in there, the calcium, and that's what gets measured in the calcium score. And as you can see in the illustration, the more plaque there is, the more calcium there is, and we've seen a pretty significant correlation between risk and the amount of calcium in the arteries. So it's a useful piece of that's relatively easy to measure on a calcium score to help give a little bit more detail about your risk. So this comes up a lot, I'll talk in a minute about the medication options that we have for reducing cardiovascular risk, and I've alluded to it a little bit by mentioning the study about statins. But I think in order to make the decision to take a medication for prevention can sometimes be mixed up in your approach to care, and it can be somewhat of an emotional decision too, because it is really you're not treating necessarily anything specific, and we're treating an idea of risk, which can sometimes make us feel, some people really like to do that, other people feel uncomfortable by using a medication. And so I think that the calcium score is nice additive assessment that can really help move us in one direction. If we're kind of on the fence, if it's not a clear cut, absolutely, I can list 10 trials that will tell me that your life is going to be better, live longer, better quality of life, fewer cardiovascular events by taking a medication. If you're in that middle zone and you're on the fence, it can be less compelling to commit to a medication, in particular if it's long term. And so if you're on the fence about kind of feeling good about making a decision about using a medication, the calcium score can be helpful to help you kind of feel, have more precise assessment of your risk and feel better about your decision and more evidence to back up your decisions. People that have had difficulty on statins in the past, but maybe reluctant to try others. We know that sometimes there can be difficulty to tolerate statins, but most of the time, in my experience, that if we try other ones, there's a class benefit from statins, but different side effects from one to the next. And so many times, if you've had side effects with one, you're able to tolerate another one without any side effects at all. But sometimes once you've had an experience of having a side effect with a medication, you can be reluctant. But if you knew that your risk was significantly higher, then you might be more inclined to make that effort. And then, and once again, sort of just a more precise assessment of risk really helps, especially when you're committing to medication long term. Lifestyle modification, absolutely. All of those things are really good at reducing cardiovascular risk. They've been well studied. They're independent risk reducing benefits, and then they also impact each other. The more I exercise, the lower my blood pressure is. The exercise itself helps to reduce the risk. The lowering of the blood pressure helps to reduce the risk. It improves your cholesterol. All of those things work together to significantly reduce your risk as a group and independently. But beyond that, it's also interesting to think about the medication options we have. And on the left, I mentioned aspirin, and I think that historically, many people were very comfortable being on aspirin. It was routinely given. You reach a certain age, and we give aspirin as a way of preventing cardiovascular events. The idea being that we know that aspirin significantly reduces cardiovascular events in people who have had a previous event. And so it made sense intuitively to think that it would help prevent it in people who have not. And so I think because of that routine use of it, people got really comfortable taking an aspirin a day. But the more that we've researched using aspirin in primary prevention, and again, it is a group of people, again, where the event rate is lower, it hasn't been as robust in terms of showing a benefit in a primary prevention population as the statins have been. So really the mainstay of medication options that we have to reduce our cardiovascular risk significantly has been statins. There's much more evidence supporting the benefit of statins in prevention than aspirin in a primary prevention population. Now, I know this came out in the news a while back, and it stimulated a lot of people to stop taking their aspirin without talking to your doctor. So please don't do that. In select patients, we do still use it for prevention. Remember how nuanced the assessment of risk is. When you're seeing your doctor and they're sitting there asking you questions, we're thinking about all those things on the list in our heads, going through our mind and really kind of getting a clinical sort of sense of risk. And so sometimes we do feel like aspirin is a good idea for you. So you always should talk to your doctor before you just start a medication like aspirin or before you stopping it. But the studies have suggested that there is more bleeding risk benefit even from a baby dose aspirin than we really appreciated before, and maybe not quite as much benefit in terms of a primary prevention risk reduction than we used to think. So there's a little bit more thinking that goes behind whether or not we should be using aspirin or whether or not aspirin is best for you. But the statins, once again, have been shown to really significantly reduce risk. And back to the calcium score for a second, is that they're in the studies that have looked at calcium scores, it showed that the higher your calcium score, not only does that signify an increased cardiovascular risk, but it's associated with more clear benefit from statin use. So it's a nice thing to know. Not only is it a marker of increasing your risk, but we know that people are more likely to derive benefit from taking a statin for risk reduction with a higher calcium score. So I think oftentimes there is some reluctance to consider statins, but in the right patient population, after a good thorough discussion with your physician about your risk, and in particular whether you need more specific advanced assessment of risk to make the decision, you can come to a discussion together to make the decision that in some patients that really can significantly reduce your risk in the long term, and it's worth considering. And just this slide is to just drive home the point that yes, statins were initially developed as a cholesterol lowering medication, and they of course do lower cholesterol. But again, even independent of what they do to control your cholesterol levels, it can reduce cardiovascular risk. And so even people whose cholesterol numbers are not excessively high, even maybe they're only mildly higher than an ideal would be, if you have enough underlying risk, then you can still derive the benefit from the statin. And in terms of mechanism, I think that's still being understood and elucidated. Likely has an effect on inflammation at the level of the blood vessel wall. But just important to remember, because I feel like in the office, at least, we'll get the question of, well, why are you even talking about this medication if my cholesterol is good or not bad? Or maybe I could just spend another 6 months and really eat well and get my cholesterol down. And that's wonderful. And absolutely, you should make that choice for many reasons, including that it has a benefit at reducing cardiovascular risk. But even when doing everything right, you still may have risk enough where the statin could add to your overall benefit and reduce things further long term. So that's the piece about statins. So in terms of additional take homes, I think what we wanted to drive home today was that knowing your risk is really important, in particular in women who sometimes are not assessed as thoroughly for risk. And that you are empowered to make lifestyle choices that will significantly reduce your risk. It's important to talk to your doctor about whether or not there's more to it than the lifestyle decisions that you've made or that you're making, and whether you have any other risk enhancing factors that might change your risk, whether additional risk stratification specific to your risk would be helpful to making a decision, and to focus on all the areas that you possibly can that will add up to reducing your long-term risk. And that's the best way that we have to really significantly improve your long-term health. Thank you.
Thank you, both Dr. Rafferty and Dr. Michelin. That was terrific. I think we all learned a lot. And I would just like to encourage the audience and remind you that if you have any questions that you'd like to submit to either of our presenters today, you would do that through the Q&A button located in the center bottom of your screen. We did receive a couple of questions from some of you on the line in advance. And so while you're thinking of other questions that you might want to ask, I will go ahead and ask some that we received in advance. Dr. Michelin, since you just talked about the presence of plaque in arteries and calcium scores, maybe you'd like to take this one. We heard from somebody, I've heard that people who have plaque buildup in their teeth and gums are more likely to have cardiovascular issues. Is this true?
So that's an interesting question. I think when just to as a from a point, this has come up several times, even just recently, about plaque. The plaque on the teeth is different than the plaque in the arteries, although we use the same word. The general sense is that we do seem to see higher rates of heart disease in people who have gum disease, but we're not certain really if that is a cause or an effect relationship. So it's because heart disease is multifactorial, there are a lot of components, and so it can be difficult to identify what is a cause and effect relationship. So smoking can have a bad effect on your oral health as well as your cardiovascular health. And in some of the studies where they looked at correcting for those who have been smokers and not smokers, there was a less robust association between oral health and cardiovascular risk. Also, poor oral health can be another risk factor in people who have other general cardiovascular risk factors as well. So it's hard to know if that's necessarily the gum disease increasing your risk, although there have been some theories to suggest that inflammation within the gums is another marker of inflammation. And we know that inflammation in the level of the blood vessel wall is a significant in the pathophysiology of our cardiovascular disease. And so in general, it is, there does seem to be some relationship there. We don't know if it's cause and effect. Good oral health is really important to the heart anyway, and just into our bodies anyway. There are other ways that poor oral health can increase our cardiovascular risk by introducing risk for infection that can involve the heart. And so even if it doesn't necessarily increase our risk for plaque in our heart arteries, there are benefits at maintaining good oral health as well. And there is reason to suggest that there may be some association in terms of risk between the two.
Thank you. That was very helpful. Another question that we received, I think you both addressed autoimmune diseases, but Dr. Rafferty, perhaps you'd help answer this question. How does autoimmune disease affect your heart? And are there specific autoimmune disorders that are worse for your heart than others? For example, lupus, Lyme, thyroid disorders.
Yeah, thank you. Good question. So the most common autoimmune disorders that are associated with increased cardiovascular risk are lupus, rheumatoid arthritis, which is actually very common in the United States, and antiphospholipid syndrome. So they've studied those at length, and we do know, for example, with rheumatoid arthritis, your longevity it decreases by about 5 to 10 years when you have a diagnosis of rheumatoid arthritis. And the mechanism, as with all things in medicine, our understanding evolves over time, and the mechanism of cardiovascular disease has always felt to be very straightforward. The plaque, you've got lipid and it expands, and when it gets to a point, it's too much, and then you have a blockage. But we know now that inflammation plays a big role in cardiovascular disease and contributing to heart attacks and to progression of coronary artery disease. And the thought is that statins actually reduce inflammation in a way, and that may be one of the mechanisms by which it's helpful, in addition to just lowering the numbers that we see in the blood panel. So these autoimmune diseases have this very high inflammatory state, and sometimes there are markers in your blood like a CRP or other blood tests that can show high inflammation. And so the mechanism of the association is felt to be that. So ultimately, the way you treat that most effectively is you get control of the disease. So if you can get control of the autoimmune disease with disease-modifying medications, then you can reduce the inflammation in that way and ultimately improve your cardiovascular risk. However, in addition to that, the idea is some of these other medications and being more aggressive about risk modifying the things that you can control. So like things like statins, like Dr. Michelin had talked about. So that's the mechanism, and those are the three major ones that we think about.
Terrific. Thank you. And we do have two additional questions, and I think we just received another question in the Q&A that I will ask. Maybe Dr. Rafferty, since you're on the line, you could stay on and answer this one. Are cardiovascular exercises required for good heart health, or can just lifting weights and strengthening muscles help protect your heart too?
Yeah, that's a really good question. And we talk about this a lot in the office. And it really is for different age groups that I see, from the younger to older. I put different emphasis on different aspects of it. But the bottom line is there's three main types of exercise. One is cardiovascular exercise. The other is strength training. And the other thing is flexibility and balance type things. And they're actually all helpful in different ways. So cardiovascular exercise, meaning walking, running, biking, where you basically get your heart rate up for a period of time and you keep it up because you're consistently doing something, and then you let your heart rate recover, is really important for lowering your blood pressure and lowering your heart rate over time. And that helps to reduce your long-term stress. So the more you do that, the more benefit you have from that standpoint. Weightlifting, you may not have the same cardiovascular heart rate and blood pressure effect, but as you build muscle, that has more of an effect on weight loss, and weight loss ultimately has an effect on your cardiovascular health. So my big thing in the office with people is that a lot of these guidelines and conversations sound very intimidating. And if you're someone who hasn't been exercising, or someone that exercise has not been a part of your life, and the idea of, the American Heart Association says you need to do 30 minutes of exercise, moderate intensity exercise 5 times a week. And that feels really overwhelming for some people. And for others, that's easy. They're already doing twice that much. So the main idea is to move and to keep your muscles strong. And that's where the pliability and flexibility comes in, because it doesn't have a huge effect on your heart health in the moment. But what it does is it keeps you moving. It helps prevent injury, and it enables you to continue to lead an active lifestyle over the course of your life, which is ultimately the best thing that you can do for yourself. And there's on CNN, Sanjay Gupta came out with it about the benefits of all these different things for preventing dementia and staving off Alzheimer's disease and all the neuro benefits that these types of things have. So it's really beneficial for your entire body. And sometimes I set a goal for people of, if you can move 5 minutes every hour, and that's what you do, that's a good start. And then when you achieve that, then you try to go to 7, and then you try to go, something that feels approachable and not intimidating, that you can stick with, and then feel really proud about what you're doing, and it will help to feed, your heart health going forward.
Perfect. Thank you very much. And this question perhaps could go to you, Dr. Michelin, from somebody in our audience. What is your opinion on using a statin when a person is pre-diabetic and mild calcium CT score, normal blood pressure, and cholesterol? Does the statin contribute to advancement to diabetes?
Great question. That's a great question. So there have been some subgroup analyses of various studies that have suggested that there may be an association between statin use and an increased risk of diabetes. You have to be very careful when interpreting that information, because statistics can be deceiving, in particular when looked at in the subgroup analyses. And again, with this idea of establishing a true cause and effect relationship. So I think that there is some data that raises the question of whether or not there is an increased risk of developing diabetes. However, it's not well established as a true cause and effect relationship. In general, people who are at an increased cardiovascular risk are also at an increased risk of developing diabetes. And so inherently that population is more likely to develop diabetes over time anyway. And so it's really not clear that the statin is the driving force behind moving that forward. It has not changed my prescribing recommendations for a few reasons. Number one, because of what I just described. Number two, the studies look at people who, in terms of prevention, and then also for primary prevention and secondary prevention. And across the board, we keep getting profound benefits in terms of what we really care about most, I think, in long-term outcomes. People live longer. They have fewer cardiovascular events from statins. And so I think the ultimate goal is just that, as opposed to focusing as much on labels. So maybe there's a slight increased risk of going from prediabetes to diabetes, but maybe that would have happened anyway. And you're still, I think, getting there's an outweighed benefit from the medication than there is a risk. So you're still, I think it's a little bit of a focus on the label. Nobody wants to have diabetes, of course, but I think if you look in the long term, in the right patient population. And now, again, there's nuance. And so the case that you described, for sure, I can't comment for sure whether you would be appropriate for a statin or not, but certainly would be a person that should have a discussion with their clinician and really look at all those features to determine that. But I wouldn't let a worry about diabetes alter the decision making in that way, because again, we're really looking to promote long-term health. We want you to live as long as you can with the best quality of life that you can possibly have and the lowest likelihood of having a cardiovascular event. And I think statins really still bring us in that direction.
Excellent. Thank you for that thoughtful answer. And it looks like we have time for one more question. So we can end with, do you have a particular diet that you recommend to your patients to lose weight healthfully? Would you like to stay on and take that, Dr. Michelin?
Sure. Yeah, that's a great question, of course, especially with all the over the years, there's always a new kind of fad diet that comes into vogue, and it's the discussion. So I try to really stay away from recommending sort of specific diets that have names, because in general, that kind of argues or that signifies a potential fad diet. And usually fad diets are not great in terms of being sustainable, which is key. And because when you make a choice about choosing a healthy diet, you want that to be not that you're on a diet, but rather that you're making sustainable long-term decisions that you can maintain, and that will be the most beneficial in terms of keeping your body healthy. That being said, I would say that the most researched diet that has shown benefit in terms of cardiovascular health is the Mediterranean diet. But really what that is it emphasizes whole foods. So foods that are not out of boxes and cans, nothing that you can order at the fast food restaurant, really trying to avoid processed foods with a lot of added salt and sugar, in particular sugar. And I think that this is one thing that we're going to be seeing more of over the next wave of research with cardiovascular health. I think the added sugar is really a sign of additives in foods that significantly increase cardiovascular risk. So whole foods that are heavy in vegetables, fruits, whole grains, really trying to avoid the refined sugars and the simple sugar foods, which are more found in processed foods. Lean meats, nuts can be beneficial for cardiovascular health, certainly fish. And then again, with the typical that we all know about, the Mediterranean diet is rich in all of those things, but generally avoids higher saturated fats and are more focused on the unsaturated, monounsaturated fats, like the olive oils, as opposed to red meat and other foods that tend to be high in saturated fats. And so of all the sort of named diets, that's the one that's been most associated with cardiovascular health. And it just drives home the benefits of just eating whole foods that are predominantly vegetables, lean meats and fish, whole grains instead of simple sugars and refined sugars and added sugars.
Excellent. Thank you very much. And it is exactly 1 o'clock. So what perfect timing. We'd like to thank both of you for presenting with us today. And thank you to everyone here on the line. A reminder that if you'd like to share this content or view this content again, it will be available on the York Hospital website, as well as on our YouTube channel sometime next week. So thank you all and happy Valentine's Day.
Thank you so much for having us.
Yes, thank you for having us, and thank you all for coming.
Take care.